Next speaker is Dr. Samir Mehta. He is Associate Professor of Medicine, University of Miami, past President of Indian Society of Interventional Cardiology, past President of American Heart Association Miami Chapter. He is Course Director of Lumen AMI Interventional Course, which he conducts at Miami. He is author of a textbook of STEMI interventions. In fact, I personally visited his lab more than a decade ago when I went to ACC in Orlando. Those days he used to do actually excimer laser, am I right? For coronary interventions. So we got a very active interventional cardiologist here going to speak to us on management of STEMI. What is the latest in 2009? What are the things we have to follow this new year or the current year, 2009?
So again, the benefits are there. Pre-hospital thrombolysis is the way to go. So that's one. This is it. That's the way to do it. Now the next question is going to be, which is the right agent? This is again, the next 4 slides are from my textbook. Who should get it? Now it's the comparison. Which patient you should do more thrombolysis? Which patient is good for primary PCI? First message. The sicker the patient, think of it in your mind. The sicker the patient, you are probably 2 things you need to do. Either very early thrombolysis, or most of them will do much better going by PCI. So patients in cardiogenic shock, anterior wall myocardial infarction, who are getting hypotensive. These are the patients, PCI is much better. You are much better on these patients. Try to make a phone call, look, can I send him to this hospital? Can I send him to Dr. Satyamurthy? At the end of the day today, you should be having their phone numbers on your cell phone, all of you. And they should tell you, you know what, we are committed. We will save this patient's life. You have a problem, you call us and we'll immediately take the patient, and this is what is happening. And I bet you this will happen. I know them for years. Somebody like Dr. Satyamurthy, you call, yeah, send the patient over. System has to get better. Now, for thrombolysis, most of the time it is going to be a person who presents very early. Somebody who gets chest pain, come quickly, give him immediate. You've seen the diagnosis, give TNK. 5 seconds, immediately it's done. Those are the ones. But the sicker ones are probably better off. And wherever there is going to be delay, you think it's going to take time, PCI. PCI is excellent for somebody 3 hours, 4 hours, 6 hours. Time is not, it's important for PCI, but it's not as important as with thrombolysis. I don't want to confuse you by saying, oh, with PCI we can sit down. No. You have to work through that. But thrombolysis, the earlier you give it, the better it is. Now these are the 2 best trials done with this. And I want to give you a point here. The Prague trial, you had an acute MI, you transferred him for PCI. And they demonstrated that even if you transferred the patient for PCI, the results were excellent. As opposed to it is this other trial where you give them early thrombolysis and you compare the result and you realize, wow. If you're able to get a good agent, this is TNK early, the patient does as well as somebody who's getting transferred. Now this is again from the book, my own textbook. I've compared these agents. There's a message here. Look at the last column here. This is the last column. And this is TNK. This is why, believe me, I have no conflict of interest. I'm the one who does PCI, but I can teach you which is the right agent to use here. And this is why it is the right agent. I think there are 4 reasons. Ease of use, why? Because you give a single bolus. And now it's not even single bolus. You can give either 30 milligrams, 40, 50, even depending, that will help you along with the cost also. It's also excellent. It opens more arteries than anything else. Highest reperfusion rate, best mode of delivery. And the same slide again here. Watch here, what's happening here. And you start wondering, what nonsense is this? $2,800 for no, that's, there you go, same slides again. These are the benefits. This is not true. And that is the beauty of living in this country. Today, here you go, this is what the price is. The US price is $2,800, your price is $534 I calculated today. And here you go, streptokinase, that's what it is going to do. What is the value of life? You are successful in those 2 tables. Streptokinase, you give a little more expensive drug, everybody's arteries open. And again, this, I think this is also the dosing, having different doses is also very important and brings the price down further. I've deliberately tried to make it, patients will ask you for the price and same efficacy at a low dose. So Indian experience, that has been covered. They've done some very good trials. I'm told there are more than 4,000 patients at 200 hospitals. The rates are very good of the vessels which are opened, and geographically they've noticed it. And these results are even better than the US. And last night I suggested to the company, I said, do some papers and compare. Why is it that maybe Indian patients' vessels are more amenable to thrombolysis? I don't know. Maybe there is a more of a thrombotic milieu which Dr. Alexander mentioned. Maybe there is something more going on to it which I think needs to be explored. And again, this has been written in all these journals. And so these were the 4 things I showed you. What are the advantages of elaxim? Ease of use, good pharmacokinetics, highest perfusion rates, good data. Along with that, you add this low price, differential prices, large Indian experience. I think your choice is a very simple